monthly health education program brought to you by Hudson Valley Hospital Center. Each month we bring you a new topic and a new guest. And this month I'm very excited to have on the show here Dr. Melita Charles from the Ashikari Breast Center.
Good morning.
Good morning. Dr. Charles is a breast surgeon here at Hudson Valley Hospital Center, and today we're going to try to clarify some issues about screening for breast cancer. So we're very happy to have you here on the show and to be able to give us a little bit about your expertise in this area. Let me just tell you a little bit about Dr. Charles before we get started with the program. Before joining the Ashikari Breast Center, Dr. Charles was a member of the Department of Surgery at SUNY Downstate at Long Island College Hospital and was clinical assistant professor of surgery there. Before that, she served as director of breast surgery at Nassau University Medical Center, and she received her undergraduate degree at Cornell University and graduated from Mount Sinai School of Medicine. She completed her residency at Albert Einstein College of Medicine and LIJ Medical Center. Dr. Charles completed clinical and research fellowships at Roswell Park Cancer Institute in Buffalo, New York. So as you can see, we're very lucky to have Dr. Charles practicing here at Hudson Valley Hospital Center. And there's many things we can talk to her about today, but we wanted to start out kind of discussing the whole issue of breast screening, screening for breast cancer, and some of the confusion or controversy that's come up. Recently there's been sort of a little bit of confusion and back and forth on when women should start having an annual mammogram or screening for breast cancer, right, and how often they should have it. And so maybe you can just tell us a little bit about what the thinking is right now.
Actually, the American Cancer Society, the recommendation that most clinicians follow, has not changed the recommendation for breast cancer screening. That is still recommended to start at age 40 and to continue as long as a woman is in good health. Women who are high risk may have different recommendations. The controversy came in because there have been several studies since probably the mid-'80s that have looked at the effectiveness of screening for breast cancer with mammography. There's been probably about a 20% benefit is felt in terms of improving mortality in women who are screened. The most recent controversy came about because of the publication of the Canadian breast cancer study. There was a national breast cancer study started in Canada in the 80s, which has been controversial since its inception. The mammography technique that was used at the time was considered substandard even for its time by expert reviewers. Right. Some people even thought about recommending that the study be canceled. What they did was they looked at women with mammography and a breast examination for 5 years. Right. They compared that to a group of women who only had clinical breast examination. And their conclusion was that there was no difference in mortality between the two groups, meaning that mammography added nothing to the benefit of screening. Right. But because of the problems with the screening and the possibility that some women in the group that was only supposed to get clinical examinations probably got mammography, right, the response is the study results are kind of blurred. So it's not clear, whether that's a study we should even look at. Other studies over the years have shown a slight benefit in mammography, in patients who are screened with mammography, rather. Mm-hmm. These days, with much more effective chemotherapy and better surgical techniques and better radiation techniques, it is possible that mammography screening seems less effective because we have so many other effective therapies to treat women even with advanced cancer these days.
Right. So how important is it? I mean, obviously that's what all these different studies are trying to measure, is that, is this really effective? Do women really need to have a mammography? And, some of that I think is also, there's some confusion as to, what type of screening to get. I know when I go for my mammography, I hear, you have dense breasts, right, you need to have an ultrasound. Some women, we now have the 3D mammography at Hudson Valley Hospital Center, or tomosynthesis, right, and what that is. So I don't know, maybe you can tell us a little bit about, what the different types of screenings are and what might be appropriate for some women versus others?
Right. So first I'll say that what we probably will move to in the future is more of a risk-based screening. Right now, it's kind of a one-size-fits-all.
Right.
You're 40, you start getting mammograms.
Right.
The U.S. Preventive Task Force recommended a few years ago that we start screening at age 50. Right. And that's because most breast cancer occurs in women in the 5th and 6th decade and onward. Mm-hmm. Not much cancer actually shows up in women under 40, even though we hear about it a lot. Right. The screening is a digital mammogram. 2 views are done of each breast, and that should be done annually. Right. In women who have dense breasts, mammography is not very effective. The breast tissue, the normal breast tissue, when it's very dense, actually blocks the X-rays, which is what a mammogram basically is. Right. In those women, we recommend an ultrasound because the ultrasound does not have the limitations of seeing through the breast tissue. It's a different type of test, mm-hmm. and it adds no radiation, which is also good. 3D mammogram or tomosynthesis is actually another study that has radiation. It actually has a higher radiation dose than mammography, and is also not usually covered by insurance, at least not as yet. That probably will change soon. Right. It does not have the limitations of mammography. It is able to do a 3D image of the breast, even in dense breast, and is an adjunctive study. Not every woman needs a 3D imaging, and not every woman needs an ultrasound. Right. If you have dense breasts, if you have a mass that can be felt, an ultrasound should be done. The other study, the tomosynthesis, we still have to do some research on. It seems to be more effective in picking up lesions than ultrasound and mammogram. It picks up a few more cancers or a few more abnormal lesions than those studies, mm-hmm. but whether that will actually translate into increased effectiveness or increased mortality is doubtful right now.
And that's because it has more views. Is that what it is?
It has more views. It's if you know what the CAT scan is, mm-hmm. It's a slice that's then reconstructed into a 3D image, so you're able to see all around that image as opposed to the 2D views that you're usually seeing with mammograms.
Right. Why do you suppose they just don't do ultrasounds on all women if it doesn't have radiation and it's better?
I mean, just as the only screening technique? Ultrasounds do not pick up calcifications. Okay. And a lot of breast cancer actually presents only as calcifications. I see. In women who have fatty breasts, when women are dense, they're usually younger. There are older women with dense breasts, but usually once women go through menopause, the breast becomes more fatty. A lot of the breast tissue recedes. It's no longer supported by the female hormones, estrogen and progesterone. So it's easy to see things in those women because the mammogram is very effective. There's nothing to really block the X-rays. Mm-hmm. In women who have dense breasts, ultrasound is very useful. And probably very soon we'll be using tomosynthesis more often. Right.
Now, am I correct in that with affordable health care, women get free, or at least their health insurance covers the screenings, like a free screening?
I don't know. I haven't heard any advertising or to that effect. However, women in New York State are actually quite fortunate. There's low cost and free screening has been available for years for women who need mammograms. And usually that's advertised. There are vans that go into community centers and offer free screening, mm-hmm. and those are usually followed up in the hospital that sends out, the van. A lot of advertising is done in community centers and churches to kind of promote, that type of screening. Mm-hmm. Women in New York State who are diagnosed with breast cancer, and actually colon cancer as well, are actually Medicaid eligible. So even if you don't have insurance and you're diagnosed with breast cancer, the state covers you, for your treatment.
That's good to know.
Yeah.
Yeah. So, while we're on this topic, I was just thinking about, this recent, I don't know how recent it is, this study that sort of talks about the greater risk that African American women have mm-hmm. for breast cancer and trying to sort of figure out, why that is. Is it hereditary? Is it genetic? Is it, just the lack of affordable health care that they can have, regular screenings?
That's mixed.
Mm-hmm.
There's going to be some effect of socioeconomic status. We know mm-hmm. that poor women in general do not get very good health care sometimes. And as we know, women tend to put family first and get themselves looked at afterwards. Right. So the specific issue with African American women is a little bit more complex. Some of it is that there is an aggressive type of breast cancer that shows up in young African American women, mm-hmm. and that's very aggressive and difficult to treat. The truth is that actually African American women have less breast cancer than Caucasian women. That's starting to change a bit, but traditionally it's always been lower. Hispanic women have a much lower rate than white women as well. So in African American women, it's not that they have more cancer, it's that when young women get it, it's very aggressive.
I see.
So when you look at, and also when you look stage for stage, black women still do less well than white women. And that seems, in terms of treatment, and that seems to be a mixed, it seems to be because some of those women don't complete their treatment. So if you take an equivalent stage white woman and an equivalent stage black woman, chances of both of them having completed all of their treatment, getting all of their chemotherapy, completing their radiation is less, especially if that woman is poor. Right. Because many times they have social issues that prevent them from getting to their treatments. They don't have childcare, they have to work, they miss appointments. Right. So that's part of the picture as well.
Right. And I mean, in terms of also, you know, it doesn't seem that you really would know if you don't have a screening that you have breast cancer. I mean, there's like a lot of pain associated with it, or you know, any of those things. So you know, until it was fairly well along, you might not notice that you had it without a screening.
Right, and if they're not getting regular visits and regular GYN exams, where most gynecologists will do a breast exam, and most family practitioners should also be doing a breast exam during an annual physical. And whether that always happens and whether the woman is proactive about her health also affects, you know, the outcome.
Right. So once a woman is diagnosed, or you know, something is found or whatever, I guess, you know, what is kind of the next step that happens?
So she feels a breast lump?
If she feels a breast lump, or if she goes for a screening and something is detected, what usually happens?
You know, it varies. Many family practitioners and gynecologists are not comfortable working up breast masses. They don't feel they have the knowledge to explain, you know, what all the steps are.
Right.
So many women will be sent then to a breast surgeon. What she needs is, if the mammogram is positive or if she feels a lump, typically the workup will be a mammogram, and if a lump can be felt, she will get an ultrasound as well. Right. At that point, a biopsy is usually recommended. And the type of biopsy will depend on whether it can be felt or whether it's only seen on the mammogram. If it's only seen on the mammogram, usually a stereotactic biopsy is recommended. If it's seen by the ultrasound, then it can be performed with the ultrasound. Sometimes it can even be performed in the doctor's office if it can be felt.
Right.
And once the biopsy results are available, if she has cancer at that point, she definitely needs to see a surgeon to start talking about what the options are for managing the cancer.
Right. So how often is it cancerous? Is it more often than not? You know, is it benign sometimes, or?
That's a good question. I think most women, especially if they're told to go see a surgeon, I mean, immediately it's, you know, a feeling of impending doom.
Right.
The vast majority of biopsies are negative.
Right.
About, depending on your suspicion, probably about 20 to 30% of them will show cancer, and sometimes even less depending on the center you're on and how apt they are to call to biopsy, you know, lesions that look benign.
Right. Now, lesions that are benign or whatever or other, can they develop into cancer? How do they treat those, or do they just leave them alone? It's just kind of,
most
it's a
of the
fatty
lesions,
mass or something.
Most of them are left alone. If something is completely benign, usually short-term follow-up will be recommended. So, for example, you might be told to get another ultrasound in 6 months, another mammogram in 6 months, just of that site that was biopsied. There are some things that are benign but are still considered high risk. For example, a woman gets a biopsy and she's told she has atypia. Atypia is part of the continuum of the development of breast cancer. So, for example, you have normal breast tissue, it becomes a little abnormal and it's atypical.
Right.
And that's just the beginning of the development of breast cancer. Some of those areas might develop later on into what's called DCIS, the very earliest stage of breast cancer, and might even develop into more advanced breast cancer. Right. So when you have atypia, we may recommend something like tamoxifen, which is a pill that blocks estrogen and will decrease the chances of those breast developing breast cancer. We may recommend that area be removed, and we will probably do closer follow-up for that woman, especially if she's in a family that has a high risk of breast cancer.
Right. What is, you know, we often hear about that. What is the link, you know, between, you know, estrogen and breast cancer and, you know, just the whole hormonal issue?
Right. Estrogen is the female hormone. And we know that women who have high levels of estrogen women who take exogenous, meaning they take estrogen in the pill form or in other forms, have a higher risk of getting some types of breast cancer.
Like the
types that are estrogen, right? The
pill.
types that are estrogen dependent. What we know about women who take hormonal therapy is that short-term use, it does not increase risk of breast cancer. So women, for example, who have menopausal symptoms and are miserable are able to take hormonal therapies to kind of relieve their symptoms. Long-term use does increase the risk of breast cancer. Once you stop taking it, however, your risk goes down to normal after a few years. So even women who take long-term estrogen, women who use oral contraceptives, or take estrogens for other reasons, their risk is while they're taking it. And then the risk goes down to normal once they stop.
Right.
We do not recommend women take estrogen for very long times. I've had patients who are on estrogen in their 60s and 70s who just never want to go through menopause.
Right. Oh.
And those women, we recommend that, yes, you have to stop. I mean, the short-term goal is good, but not being on it for 30 more years.
Right.
Right,
I understand. So going back to the diagnosis, we had the biopsy or whatever, it does turn out that it is cancer. And now, the woman sort of is like, okay, what do I do? I mean, you go online and there's so many different things, there's so many different, not only diagnoses, but, so the treatments are so different. How do you work with the patient when they first come into you? I know obviously it's probably emotionally a real...
It can be very difficult, especially in any women, but certainly women who are very young, it can be quite disheartening, for them, especially they have young children, they worry about their families, but it's difficult for any woman. In terms of the surgical options, when a woman comes in to me as a surgeon, I talk to her about the surgical options, but as somebody who's a surgical oncologist, we also talk about the spectrum of breast cancer care. They will need surgery, some may need chemotherapy, some may need radiation treatment, and the choices she makes will depend on some of the information that she has gotten from the internet. I'm a fan of the internet, and I think it's helpful and harmful. I mean, women who go to well-vetted sources like the American Cancer Society, some of the individual hospitals like Memorial Hospital and the Mayo Clinic, we have some information on our website about breast cancer care. Some of the media outlets like the New York Times has excellent information on breast cancer. What I tell patients to avoid is, going to some individual's breast cancer site. Women write blogs about their breast cancer experience, and those are very individual. And what that woman chose, for example, Angelina Jolie made certain choices. Remember when, Suzanne Summers was diagnosed with breast cancer, and she made specific choices about avoiding chemotherapy and avoiding certain things that, really should be done in conjunction with a trained professional.
Right.
So I talked to them about the surgical options, which are removing the lump or removing the breast. Basically, it comes down to those two options.
Right.
With removing the lump, because there's still breast tissue left behind, we recommend radiation treatment.
Right.
Whether a woman gets chemotherapy or hormonal therapy will depend on the individual characteristics of her tumor, how large it is, whether the lymph nodes are involved.
Right. Well, it was something that we have here at the hospital, the IORT, the intraoperative radiation.
Yeah.
What exactly is that? Is that, I know that's radiation during surgery, but how does that work?
So normally radiation is given after surgery. It's given for 6 weeks for a few minutes at a time to build you up to a final dose.
Right.
What they also do with the what's called external radiation, they also give what's called a boost. A higher concentration is given to where the tumor was, to the tumor bed is how we refer to it. So what the intraoperative radiation treatment does is it gives that boost, but it gives it when the wound is open. So you're not going through the skin. When you do it externally, you're guessing a little bit. I mean, you know where it is. You see a scar. You do a CAT scan to kind of directly image where that region was. But if you think about it, common sense, the wound is open. You're putting it directly where the tumor was. You're giving a dose that's a little bit higher, right to where the tumor was, and it only goes for a short distance. So you're really just treating that local area. It does not replace the external beam therapy in many women. But if you can imagine an older woman, somebody who's maybe 70 or 80, who has a small cancer, it may be that one boost of intraoperative radiation is enough to treat her.
Right.
Younger women are not usually recommended this as a sole treatment. They have many years of life ahead of them with a higher chance of the cancer coming back. It is something that we are participating in 2 trials with the intraoperative radiation treatment. And it's been an interesting, interesting watching these patients and following them up. There's still some time before we can really gather the data to see how well it does in comparison to the traditional treatments.
Right. Just a quick point when you mentioned about younger women versus older women. Is that because the cancer grows slower in older people, or just because they have less of a time of longevity?
It's both. It's mostly because older women tend to have very slow-growing tumors that are less aggressive and that are hormone sensitive. Right. Younger women in their, especially women who are in their 30s and 40s, the group of African-American women I mentioned who have aggressive cancers tend to be hormone negative. Right. They tend to be what's called triple negative. They don't show estrogen, they don't show progesterone, and they have also no availability of the Herceptin receptor is not there. They tend to only respond to chemotherapy.
Right.
And they have fewer options than women who have hormone-sensitive cancer.
I see. Yeah. So you mentioned Angelina Jolie, and I think that was kind of interesting because I was going to get into the whole, in terms of the genetic predisposition for cancer, and that's something that is discussed widely now, not just because of Angelina Jolie and prophylactic mastectomies and all that. How accurate is that testing, and how does that affect like a woman's choice in terms of what she does?
Well, the first thing to know is that the breast cancer gene is not very common, and that actually the percentage of women who are diagnosed with breast cancer who have a genetic component is only about 10%. Right. That's pretty much true across the board for different types of cancers. Women overestimate their risk of breast cancer in that sense. And the fact that your grandmother, Sadie, had breast cancer at 80 does not significantly increase your risk. Women with a high-risk family tend to have multiple family members, multiple generations who have breast cancer. Those are the women who are most likely to find a gene in. And even then, we still don't find a gene in the vast majority of them. Right. The initial studies were done in Ashkenazi Jews. There was a high incidence of breast cancer in that population, so it made sense to target them, to find a gene. When you look at that gene in other populations, you don't find it very often, and even among Jewish women, you don't find it, very often. You're more suspicious in women from certain backgrounds and with certain family trees. There are other genetic syndromes that increase the chances of you getting breast cancer. It also, for example, there's a Li-Fraumeni syndrome, there's Lynch syndrome. All of these things increase your risk of breast cancer. And there are genetic panels that can be done in women who have a family tree that shows a pattern of certain types of cancers. Right. And some of those women will benefit from speaking to a genetic counselor to really see what the risks are. Some women think that a certain person had breast cancer, but they didn't actually have cancer. Some women think somebody had colon cancer, but it was a benign lesion. So it's good to have somebody really tease out the details.
Right, of your
and also you have to consider what you will do if you have that information. Right. Angelina Jolie, for example, had the breast cancer gene and had a family history that had a strong incidence of breast and ovarian cancer. And she made the decision to have prophylactic mastectomy. Right. I have met patients who know that they are positive for the breast cancer gene who refuse to have surgery. Right. So if you're not going to do anything with that information, then maybe it's not necessary for you to go through the testing.
Exactly.
So you have to understand.
If you know ahead of time that you're not going to do anything, then there's really no point in knowing.
Right. I mean, it's useful information for perhaps for if you have daughters, if you're a woman who's diagnosed with breast cancer and you may have the gene, you may want to find that information out for your sisters, for your children. Because you may already have cancer, but still that information is useful to other members of your family and to you if you decide to make decisions about the other breast tissue that may still be left behind.
Well, I think you're absolutely right about the hereditary factor. I think a lot of women are like, oh, I don't know, there's never been any breast cancer in my family. I don't have to worry about it. Not really knowing that most breast cancers are have nothing to do with hereditary.
I don't know how that became such a pervasive thought. Most women will tell you that. Well, no one in my family has breast cancer, and we're like, yes, that's the most common thing. Most people aren't going to have breast cancer. Right. Even though we see a lot of breast cancer, it's still about 12% of women lifetime women have about 12% lifetime risk of getting cancer. Right. That still leaves a ton of women who will never get breast cancer.
Right. Thank God.
Exactly.
So,
yeah.
but anyway, just the whole idea of all the different treatments that are involved or whatever, and just getting advice in general and getting regular screenings, I guess, is what women can really do.
Correct.
To prevent, breast cancer. I mean, there's nothing, you can really do other than that. So.
Well, there are probably some lifestyle factors that we can do. We know that there are lifestyle risks. Alcohol is a strong risk factor for breast cancer. And although we have told people a little bit of alcohol is beneficial for cardiovascular health, now we're starting to think that as far as breast cancer risk, that there is really no safe level, for alcohol. Smoking does increase the risk of breast cancer, something that we never really thought until very recently. So those are two things that are certainly within our capability as far as controlling risks.
And diet,
Diet is a little dicey. We don't have any clear data that says that any particular diet is beneficial. We do know that obesity increases your risk of breast cancer, especially women who are obese postmenopausally, because at that time estrogen is made from fat tissue. So if you have a lot of adipose tissue, you have an increased risk of breast cancer. But, vegetarians, it really seems to be more reproductive changes that have led to increased incidence of breast cancer, not so much dietary changes. Because when we look at countries that had a very low risk of breast cancer previously, now that for instance, India, where it's now becoming more urban, women are having fewer children, they're having them later because they're, becoming educated, the incidence of breast cancer will increase in those countries. Because that's the pattern that happened in the U.S.
Well, it's been fascinating. I could probably talk for another 45 minutes just about this topic because it really is interesting, and I think that it's very prevalent, and people want to know. Women, obviously, especially, want to know about their risk and breast cancer and what needs to be done. But I'm just, closing, out here. We just, if there's any particular advice that you would give to women who are diagnosed. In terms of what steps they should take and, what they should do.
Well, I think your doctor is your advocate. There is a tremendous amount of support out there for people with breast cancer. And once you're diagnosed, your family doctor will certainly refer you to somebody who has more expertise in treating that condition. And there's a lot of expertise available. We know a lot now about breast cancer. We probably study it more than we've studied any other cancer. And I think women has a very good chance. Most women who are diagnosed, especially with stage 1 or 2 cancer these days, will live out pretty much a normal lifespan.
Right.
We do a very good job of taking care of them.
That's true. That's very good to know and very comforting. And, we have support groups and things out there for people now that we didn't maybe previously have. So I think that, women should not, totally panic.
Shouldn't lose hope.
Right, exactly.
They
shouldn't.
Diagnosed with breast cancer, correct.
Exactly.
Correct.
So, well, thank you so much for being on the show today. And if people want to get more information about the Ashikari Breast Center, I know that there is information on the hospital's website, and you also have your own website.
The Ashikari Breast Center does have its own website, correct?
Has its own website. So.
And you can find us on the Hudson Valley website
as well.
Yeah.
Okay. Any other websites that you would recommend to patients in terms of just getting general information?
General information about breast cancer. The American Cancer Society has excellent information that's patient-friendly and is also in multiple languages, at least in Spanish. I'm not sure if it's in other languages. So there's the National Cancer Institute, and there's great information on some of the media outlets like the New York Times, and they're very well-vetted sources, and I think the information is very good.
Right. I think that's helpful to people in general, just to be able to research it a little bit beforehand.
Yeah, I like them to be educated, when they come in. It's nice to, I give them a lot of information when they come in, but obviously you can't take it all in at once. Right. So the availability of other information is useful, and I also give them some reading material at the same time.
Okay, great. Well, thank you so much for coming on our show today and giving us this information. It's very helpful and useful to people.
You're welcome.
That's another Health Smart show, and we will be back next month with a new guest, a new topic, and until then, be well.